waiting for a few more people to log into this, but I think we'll make a start. And so we may get some late people coming on, but it's not fair on the people that have already logged in on time. So for the next 45 minutes or so, I'm going to talk about medially deviated subtalar joint axes, and I want to explain a little bit about it and also the clinical implications and what it means to us in clinic. So just to introduce it, what we're going to look at is what exactly a medially deviated subtalar joint axis is. I'm going to go into a little bit of physics about it, but not too much, because I know people don't tend to like physics really. What patients have this? Are these the sort of patients that we'd recognise as they come into our clinic? Do we have to test everyone for it, or are there any red flags which might highlight who we would test? We'll look at the different ways to assess for it as well. There's a couple of different tests and different ways of doing it, so we'll go through that. And what difference it makes to our prescription, and do we consider that? What does it mean clinically? So is it likely that if someone has a medial axis, it will be a precursor to injury, or can it affect the way we've designed an orthotic or an orthoses? And I'll also touch on how we manage it with an orthotic, both with a functional foot orthoses and just normal off-the-shelf devices that we might use day to day. So who are these patients? I've put a picture up on the right-hand side there of what I think you'll all agree is an excessively pronated foot. Now this is a little bit tricky for me because we're doing a webinar, so I can't get any audience feedback whatsoever, and it feels a little bit weird because I'm just looking at a wall and looking out my window into the garden. Normally at this stage I try and get a show of hands as to what sort of clinics people work in, what professions we've got. So I'm assuming I'm talking to podiatrists, but as I say, there might be physios there, might have chiropractors, I might have a whole plethora of people listening. Interestingly, when I've asked this question, when I've given similar presentations in the UK, it seems to depend where I am geographically as to how common they see these sort of foot types or how they see a supinated foot type. So I always thought that was quite interesting, and I'm sure that would make a good research project for somebody somewhere. But aside from that, I think we'll all agree that that's probably a fairly commonish sight we will see in our clinics. So it's an excessively pronated foot. With a medially deviated axis, you tend to see a convex shape to the midline of the foot. So along here, hardly any profile, hardly any arch profile whatsoever. And that's because there's a medial rotation of the talar head on the subtalar joint axis if it's medially deviated. So you get this very, very bulging, flattening arch. If we looked at this patient from behind, so if we look down the back of the Achilles there, and looked at the back of the heels, what we tend to also see is a bulging here underneath the medial malleoli on both sides. If we then came around the front and looked at the tibias, you tend to see that the tibia would want to point more towards the first metatarsal phalangeal joint. And again, that's for the same reason as the convex shape of the foot. It's due to the medial rotation of the talar head on the subtalar joint axis. Now, I've put down the bottom there with a question mark post-tib dysfunction. So I'm not saying that every patient you see with post-tib dysfunction will have a medial axis, or anyone with a medial axis will then go on to develop post-tib dysfunction. But with the patients that tend to come in with that sort of foot type, you do tend to find that the two sometimes go hand in hand. And really that's because of the position of the insertion of the post-tib relative to where the axis lies. And I'll touch on that a little bit later on and the relevance of that. So how frequently do we see these patients? I think if you asked me, I'd say it would depend entirely on the sort of clinic that you have and the sort of patients you see. So when I worked in private practice, I had sports clubs on my books, so I tended to see the same patients over and over again. So I probably wouldn't necessarily have had the same findings as I've put up here. There's no specific evidence on this. No one's done any research studies looking at populations. This is just the observations of an expert who specialises in this field. So some of you have probably heard of Dr. Kevin Kirby, who's written lots of papers about medially deviated axes, and some of those I've quoted in the reference slide at the end, so that might be an idea for further reading for some of you that want to look at this in more depth. And this was an e-talk or a webinar where he was asked questions, and basically he said in 28 years of his practice he would estimate that 50% the clinical population had a subtalar joint axis which was either slightly to severely mediated. So, to say, I wouldn't have said it was that high with the patients I've seen, but I guess it depends on what sort of clinic you run. He then went on to say probably 40% of the population, or his clinical population, had an axis which was normal, and then just 10% had a subtalar joint axis which was more laterally deviated. What he did specify here was it cannot predict pathology. So there seemed to be no rhyme nor reason as to what patients came in with which pathologies, even if they all had a medial axis. So it still seems as if everyone's different. As I say, you can't categorise it or put people in a box quite as much as you possibly want to. So this slide I've put in just to make us think, again, I guess outside the box. Also, it breaks up the slides and all the text. Is to think really if we always, tend to do the same prescription when we see a similar foot. And I know possibly, I've certainly been guilty of this in the past. If you're running late, the patients come in late, you've only got 10 minutes to see them. Or if they come in with an excessively pronated foot, and you can pretty much guess as soon as they've taken their shoes and socks off what they're going to complain of and what you're going to prescribe before you've even assessed them. Obviously that's not the right way to do it, but I think a lot of us will probably admit to doing that at some point. So it's just to think that every patient is different, and we should take into consideration our assessment before we decide too hastily what prescription we're going to give them, whether it's an off-the-shelf or all the way through to a fully functional foot or facies. So looking at the subtalar joint axis, a chap called Manta described this back in 1941, and it's a nice analogy really. He describes it as being 42 degrees from the base here, so an inclination of 42 degrees. And then if we look at it looking down here on a transverse view, 16 degrees here from the midline of the foot. Now that looks nice and easy, and it's categorised into a nice little mathematical law, but you can't apply mathematical laws, unfortunately, to soft tissue. So although this is looking at the skeleton, you've got lots of ligaments, bones, muscles, tissues, and none of those can have mathematical laws attributed to them. And I think that's been recognised and appreciated more in recent years, which is one of the reasons that many clinicians now don't measure don't measure things like RCSPs and NCSPs, because of, as I say, it can't be categorised this well into a nice little box. So probably more accurately now, it's described as being a bundle of axes where it depends on the position of the subtalar joint, or which way the subtalar joint's moving, and it tends to fall in that range. So instead of having an axis which comes exactly 16 degrees from the midline, a normal could sort of fit anywhere in between that range, and it normally, as I say, does come in between there. So what is normal? And I put normal in inverted commas there because how do you define normal? But generally it's widely believed that it should be between the sort of second and first metatarsal phalangeal joint, which actually isn't too far off what Manta said in 1941 with the 16 degrees away from the midline. I will stress though that there is no evidence to support this, so again it's based a lot on people's observations and practice. There's no research to say that's what normal should be. But then with a lot of tests and assessments that we do on the foot, it's very difficult to specify exactly what normal is. So the subtalar joint axis location, why do we even care? What difference does it make to what we do? Well, in a nutshell, we look here, this is our fairly normal axis coming up, and on the right-hand side is the medially deviated one, so you can see this has come further over to the medial side of the foot. Any force which we put this side of the axis, so if we push up on this side of the foot, it will push the foot over and supinate the foot. And then any force or posting or padding or pushing up or ground reaction force that we put on the lateral side, on this side of the axis, it will push the foot in or pronate the foot. And the relevance of that comes really when we think about the adaptations which we're going to put onto our device, whether casted or off the shelf. So any medial posting, for argument's sake, rear foot that we put on here would probably have the same effect on a medially deviated axis. But if we put forefoot posting underneath here, if the axis is medially deviated, suddenly it becomes the wrong side of the axis. So any forefoot posting rather would be pushing it the wrong way. So you'd have two bits of posting effectively skewing the foot in the middle. So the moments of the muscle forces and the ground reaction force are dependent upon the location of this subtalar joint axis. And really this is important when you think about where you're applying your posting or your prescription. So if we think about our anatomy and look back at this slide again, I think the easiest example to give would be the post-tib muscle. So that's one of the main inverters of the foot. So, there's my mouse gone. So that inserts into the medial navicular, around about here. So the function of that muscle, and I know there's lots of other muscles involved as well, but just for simplicity's sake, the function of that muscle is to hold the foot up and in the position that we want it to be in. Now here we've got a fairly normal lever arm, so it has to work sort of an average amount of work force. If the axis is medially deviated, you've got a much shorter lever arm, so that post-tib muscle has got to work a lot harder to then hold the foot in the right position. And that relates to what I was saying earlier about the two things going hand in hand. So the post-tib generally has to work harder the more medially deviated the axis. So I've just used one example of a muscle there. Obviously there's lots of others. We could think about it the other side and look at the perineal muscles. And I think at this point I would stress that it is important to know your anatomy because without that it's very difficult to work out what's working where and what's having to work harder or compensate. And by knowing that, it makes it a lot easier to diagnose your patient, make a prescription, and then if the prescription doesn't work, then you can work back and think about different things to try. So the physics behind it, as I said before, I don't want to go into huge realms and depths about physics. In my experience, and again this is where I'd normally ask the audience what they think about physics, generally people think it's boring or they don't like it or they don't understand it. And I've heard various podiatrists before just saying, well, you know, I don't do physics. Well, the thing is we all do physics in everyday life and we don't even think about it. If I gave you all, well hopefully all of you, a door and asked you to put a door handle on it, I think probably all of you would put it here instead of right next to the hinge. And the reason for that is because you've got a much longer moment arm between the hinge and the door handle. So you can relate that to the foot. If we pretend the hinge is the axis, the muscle attachment is the door handle, the further away that is from the axis, the less work you have to do to move that foot. So it's the same when you open or close a door. It's much less effort if the door handle's here, the door handle's right next to the axis, then you've got to work a lot harder to open that. And it's a similar kind of thing, really. So medial, lateral, or normal. Now the position can lie anywhere in between these three, but generally it's much easier to categorise it into three. So after we're doing our assessment, we can say whether they've got a normal axis or relatively normal, whether it's medial or whether it's lateral. So if we look here, we've got a reasonable amount of space between the medial side of the foot and the axis. It's a lot less there on the medially deviated axis, and we've got a lot more there on the laterally deviated axis. So just to give you an example, if we chose to do a medial heel skive, we could do that with an excessively pronated foot if they just got a normal axis, and that may work very well. It would certainly work very well for a medially deviated axis because remember we've only got this area here to put any correction on. But if we put something with a high force like a medial heel skive on a laterally deviated axis, you're putting a high force here with a big lever arm, and they're the sort of patients that you may be likely, if you prescribe them wrong, to end up giving lateral ankle sprains to. So it's worth thinking, as I say, about your prescription before you give it to them. So let's think about what we do already if we've got a patient excessively pronate. Some of you will just put some posting on the rear foot, but there's lots of other things that we can consider as well to decrease those pronatory forces. Again, this is either with functional foot orthosis or off the shelf. But more or less, if we've got a pronated foot, anything we put this side of the axis is going to tip it the other way or supinate it. So we could put a 4-foot varus extension on there, a 4-foot varus wedge. Most of the medial arch support there, or most of the medial arch could have some filling into it. We could have a medial rear foot post, which I think is probably the most common. If they're excessively pronating or we need a bit more control, we could go with a Kirby Skive, a medial Skive, or a Mosai. And we could also go with a first Met shaft or a Morton's extension. So there's probably many more out there. There's probably others that some of you use, but those are probably the ones I would say are the most common. Now, if we wanted to tip the foot the other way, or if we wanted to decrease supination forces, then we're pretty much doing the opposite, and we can put anything we want on the lateral side of the foot to then try and pronate it, offload it, or bring the foot in. As I say, I'm being a bit vague with that, but it depends what you're trying to do and what you're trying to treat. But we could put a 4-foot valgus extension on there, 4-foot valgus wedge, lateral arch support, lateral rear foot wedge, lateral Skive, or reverse Mortons. Not quite so common doing that sort of thing, but or treating the foot to try and make it, say, pronate more, but they are prescription methods that we have used at some point. Now, if we've got a medially deviated axis, what difference is this going to make to our excessively pronated foot that we just talked about treating with all those different modalities? Well, first of all, the position of the axis will affect how that orthosis or that orthotic works. So any 4-foot additions that we've talked about before will now lie either lateral to it or they will lie on the axis line. So if we put a 4-foot post on, we're now, as I said previously, pushing the foot the wrong way. And they're the sort of patients that come in and say their conditions aren't really getting better, their symptoms aren't improving, and they feel pain about the midfoot as if something's skewing the foot. Also, if patients come back and they say they feel like they're walking on a lump, the likelihood is it's because you've got a correction right underneath the axis. So an arch support that lies on the axis, because the axis won't move one way or the other at that point there, it just feels like they're walking on a hard lump underneath their device. And that could explain why some patients, you see, can't tolerate an off-the-shelf device with a built-in arch support. So how do we find these axes? It's simple when you know what you're looking for. When I first learnt about this when I wasn't long out of university, I couldn't make sense of it at all. And it wasn't until I'd seen a patient and assessed the patient and found a medial axis and then a lateral axis that I really learned to differentiate between all of them. And I think my tip here would be is even if you don't need to look, if you get into a habit of regularly checking this on patients, then when you do have something that's different, then it's much easier to spot, and you also get used to testing for it. So there's different ways of doing it. This is a picture here. I haven't referenced it, but it comes from one of the Kirby papers. Now we're looking here with the foot in a supine position. Personally, I prefer to do it with the patient laying prone with their feet hanging off the end of the couch. And my personal reasons for doing that is you can get your patient to completely relax and they're not trying to help you. Sometimes I found when I've done it this way, the patient tries to hold the foot and they try and supinate it or pronate it to help you, even if you tell them to completely relax. But essentially, all you're doing is, if you put a force, and you'll be pushing directly upwards with your thumb here, not coming at it with any angle. If you put a force on the medial side of the foot here, you're going to cause the foot to roll in or supinate. If you put it exactly on the axis, it's not going to supinate, it's not going to pronate, you're just going to get a little bit of plantar flexion and dorsiflexion, or once you get right underneath the tip and fib, you won't get any movement at all. And then as you come further over to the lateral side of the foot, you're going to feel the foot pronate. The reason we have the thumb in this position here is so that you can feel whether it's going inwards or outwards or pronating or supinating. So you start at the heel, and it doesn't matter if you're doing this prone or supine, either way, you start at the heel, and then once you get to that point where it doesn't go one way or the other, you mark it with a little cross, and then you come up the foot, and you do the same thing here and here, and then you keep working your way in until you find that point at which you get in either pronation or supination. Now I've seen people do this and they spend about 10 minutes doing it and they've got about 27 crosses all the way up the centre of the foot. You probably only need to do about 3 or 4 to get a good idea about whether the axis is going to go off in that direction, through the middle there, or off to the medial side. But my top tip with this would be practice makes perfect. And once you've done it several times and you've got used to what you're looking for, this takes probably about 20 seconds to do. So even if you've only got 10 minutes to assess a patient and prescribe something, it really doesn't add too much onto the time. Now, another test you can do, excuse me, I'll just take a sip of water. Another test you can do is a supination resistance test. I probably wouldn't do this on its own. I'd always do the test I've just shown you first, but this is a good way to back up if you're not entirely sure with what you've found. Now, this is evidence-based. Paper by Noakes and Payne in 2003 found a reliability and a correlation to the subtalar joint axis position by doing this test. And what they suggested is if you've got a medially deviated subtalar joint axis, you had a high supination resistance. And if you had a laterally deviated axis, you'd have a low supination resistance. So basically the test, you're putting two fingers underneath the navicular and you're trying to lift the foot up, or you're trying to put a supinatory force on that foot to see how hard or easy it is. When I've explained this before, people have said, well, this is ridiculous because if you've got a heavy person, it'll be hard, and if you've got a light person, it'll be easy. But that's really not the case at all. And again, I would urge you to try this on different patients just to get a feel for it if you're not already familiar with doing this already. So I've seen 8-year-old children who weigh very little, and I've struggled to lift their whole foot with my whole hand, reaching over them and pulling it with as much might as I can because they're so severely pronated and they've got a medial axis. I've also seen big 15-stone rugby players with lateral ankle instability in the lateral axis, and I've almost put my little finger under there, tipped it, and the whole foot's gone over. So it really doesn't have anything to do with the weight of the patient. It's just about where that axis lies and how hard the muscles are working. So it doesn't take very long again. And as I said before, it's a nice handy little test that you can have in your toolbox. So I've talked a lot about the boring stuff, if you like, the ins and outs of it. I've got a couple of case studies now to hopefully sort of bring some of it together. So this case study now really looks at how possibly a medially deviated axis led to the injury in the first place. So she was a 33-year-old female, quite fit and active, 64 kilos, so she wasn't overweight. And she came into clinic with right-sided medial ankle pain. So a bit unusual because normally we see people with inversion sprains, but she specifically medially inverted her ankle. And she'd done this at a gym class, somehow or another, landing awkwardly on a Reebok step. So I don't quite know what they were doing, but she inverted her foot and had the problem and then came to see me. So symptoms were aggravated by activity and resolved with rest. So she had no other medical history at all, no other problems. So it was one of those sort of nice, easy case study type patients that came in. So I have a little look at the anatomy there, and this is quite crude. I haven't got any of the ligaments or any of the smaller anatomy. But we've got our Achilles tendon that comes down the back, flexor hallucis longus, flexor digitorum longus, tib ant there, tib post. So I suspect it probably was the post-tib or tib-post tendon. So we did some tests to check that. So pain was only present when the tib-post, at the tib-post insertion, so when I manipulated the navicular, or palpated the navicular rather, with resisted inversion on the right side only. So when she tried to resist an inversion movement, then she really got the pain on there. She also had mild pain on the distal 2/3 of the tib-post tendon with this test. Pain on palpation, as I just said, of the navicular. She was able to tiptoe stand, but it was quite uncomfortable on the right. No obvious deformity with the right compared to the left, as both feet look pretty much the same. Both, in my opinion, were excessively pronated with a foot posture index of +9, and when I looked at the subtalar joint axis, both of them were getting on for a bit of medial deviation there. So we can see there some bulging underneath the medial malleoli. There is a little bit of an arch there, so it's not a severe case. And then this is where the axis line lay along here. So it could have been a lot worse, but it was by no means what we call normal, which would have come down through between the first and second toes. So instantly that tells us that whatever prescription we're going to give, I'm only going to post or correct on this side here. I'm not going to do anything further down. So this was my diagnosis: tibialis posterior insertitis, caused by inversion sprain or an inversion sprain, resulting in acute traumatic injury of the tibialis posterior tendon at its insertion into the navicular. Now that sounds a little bit over the top for a diagnosis, and I probably wouldn't bother doing that for a diagnosis box for everyone. But it is a good habit to get into if you've got the time. If you can be as specific as you can about a diagnosis and what's causing what, it's much easier to work out the etiology. Again, this depends very much on knowing your anatomy. And not only does it make it easier to work out what's causing the problem, but again, if your prescription doesn't work properly, then you can go back and you've got something to go from rather than working blindly. Now, some of you I might be preaching to the converted, and you might do this already, but I've seen numerous NHS trusts where if they have even had a diagnosis box, and some assessment forms don't have a diagnosis box at all, but I have seen numerous ones where people have filled in the diagnosis as overpronation. Well, overpronation is about as much use as saying that they've got blue eyes, brown hair, blonde hair. All it's doing is describing, it's not telling you what the actual diagnosis is. So if you don't do that already, it is a good habit to get into. So the mechanism of injury, going back to our patient again. Again, I wouldn't probably do this for every patient, but if you've got the time, it's a good habit to get into. Think about considering the research behind what you're looking at. So Kirby in 2000 said that the tib-post tendon divides into three, although you probably knew it before 2000. The anterior portion inserts into the navicular and plantar cuneiform, and it has its largest inversion moment arm about the subtalar joint. So that muscle pretty much does most of the work when it's trying to invert the foot in relation to the subtalar joint. Also, although it divides into three, the main part that does most of the work is the bit that goes into the navicular. So normally if there is a sprain or something goes with this muscle, usually that's the place where it tends to hurt or tends to pull, or you tend to get maybe an avulsion or something. Blake in 94 said that increased stress occurs at this tendon as it tries to compensate for increased supinatory, pronatory movement and velocity during physical activity. So again, that relates a little bit to what we said, what Emma Hauser said in 2004. And then finally, Lewis in 2007 said the position and orientation of the subtalar joint axis relative to the anatomical structures, so relative to the post-tib or the perineals, or whichever muscle you're looking at, directly determines the subtalar joint moments of the muscle, ligaments and ground reaction forces. So he's really summing up what I've said earlier, that where the axis is depends on how hard those muscles have to work regarding trying to supinate or pronate the foot. Now, I haven't gone on with that patient to say how we treated it. Actually, what we did, this case study was really more about looking at how the injury was caused in the first place because of her having a medially deviated axis. There's a few very crude pictures there just to try and illustrate it. So this is a normal axis that comes down the back of the foot. So if we assume we're just looking at the anatomy, we're looking at the right foot here, and this is the calcaneus. There's your tibia and fibia, and here is our post-tib muscle with its insertion. There's your ground reaction force, and there's your body weight. And this is the energy expenditure by the muscle. So it has to work reasonably hard to hold the foot up in the right position. But then when we've got a medially deviated axis and she's fallen off a Reebok step, suddenly you've got a small lever arm there, a big lever arm where the force is coming from, where she's had that sprain, and the post-tib muscle has got to work an awful lot harder to try and rectify or hold that foot in the right position, which in this case, with this patient, obviously didn't work because she ended up having a sprain right where the post-tib inserted. So, as I've just said, I haven't gone into what we did with the treatment. Actually, with this patient, I just gave her an off-the-shelf device with some posting because she'd had no previous problems at all. So really what we were looking at doing was just trying to offload that post-tib muscle from a tissue stress perspective rather than getting her in functional foot orthoses, which she was going to wear indefinitely. She's still on our books, so I guess maybe she will come back at some point and we'll make something more permanent. But at the moment, the off-the-shelf devices worked perfectly well and she's back to doing her Reebok steps. Right, this is a completely different case study. We're looking at a 12-year-old girl there This isn't an actual photograph which I took. This is probably going back about 10 years now, and I certainly didn't have a mobile phone at the time that took photographs. So this picture here is just to give you an idea of the sort of foot position she did have. And I remember specifically she was sort of, well, grossly pronated. She had a lot of medial bulging and the foot was completely flat to the ground. I'd actually seen her at a review appointment, so one of my colleagues had seen her previously, and she'd originally been referred with knee pain and good old excessive pronation. So my colleague had prescribed her functional foot orthoses, because 10 years ago, there was hardly anything on the market off the shelf for children's devices, let alone very excessively pronated, so she's been casted straight away. And that's pretty much an idea of what she'd been issued with. So it was a polyprop shell, 8-degree rear foot post, 4-degree forefoot post, a valgus fill, a Kirby Skive, a high medial phalange. Now that looks like quite an aggressive prescription, but if you'd have seen this girl, you probably would have been inclined to agree with it. Anything less than that, she probably would have completely squashed. So I issued them. She came back 6 weeks later, and the orthoses were uncomfortable. The knee pain was no better. She now had lumbar back pain. It felt like she was walking on a lump, and she was experiencing mid-tarsal pain. So it was one of those nightmare situations where she'd come back after our treatment with more problems than she started with. So all in all, not particularly successful. So it was a case of going back to the drawing board. So we reassessed her and found she did have a medially deviated subtalar joint axis, and it was very medially deviated, and probably one of the first ones that, not one of the first ones I saw, but one of the ones early on that had an impact because of how it affected her prescription. So what that meant, if we look back 2 slides, the rear foot posts were okay, the polyprop shell was okay, but the forefoot posts were tipping the foot the wrong way, and the valgus fill was just pushing up underneath the axis, and also probably pushing the foot the wrong way. The Kirby Skive was okay, and the medial flange just helped support the foot. But out of the 4 in the middle, 2 of those things which we've done were actually having an adverse effect on what we were trying to do. So we then recast her, we kept the medial heel skive, we kept the high medial phalange and the 6-degree medial post, but we completely flattened out the arch profile and had no forefoot posting on there whatsoever. And 6 weeks later, all symptoms were much improved. She also had strengthening exercises and stretching exercises, but as I say, this is what we did to the orthoses, and it made a huge difference. So I suppose the point I'm making there was we could have seen another child with an equally excessively pronated hypermobile foot who didn't have a median axis, and we probably would have done the first prescription, and that would have worked very well. So although 2 feet looked the same, just on the fact that the axis was in a different position made a complete difference on that patient and how we resolved her symptoms. So what about chair-side adaptations? Often I think with a medial axis, it generally tends to be thought that you can only use FFOs because you have to have a Kirby Skive. But what about the short term, like in our case study, when someone's just come in with an injury and they don't need devices for a long time? And also, what about if you're trying something before casting? If you're in a private practice, you don't always want to jump straight into a casted device before you've tried something else out first. Often a chair-side device, particularly in recent years, can be enough or a good place to start before casting, or they can be just good enough on their own. Not all chair-side devices are the same, so you can't really, or I believe you can't really have a sort of a case of a one-size-fits-all stash to keep in your clinic. I don't mean one size, but one device. So if you only ever use one off-the-shelf device that's got what you usually have, your medial arch support, and then you can add posting to, that's not necessarily going to work for every patient. And the best results usually come from selecting the best chair-side device for your patient. And if you do that, you don't often have to cast that often. So I like these ones, and they're great for people who have got a medially deviated axis, really because it takes all those requirements into account, whereas other off-the-shelf devices don't necessarily think specifically about certain foot types that specifically. So it comes full length, the full length EVA insole available in low and medium densities. So the low one works really well if you've got perhaps an elderly patient who's got some arthritic changes and you haven't got that much movement to correct. So what you might be doing there is looking to support the deformity you've already got and perhaps take the weight off something like the post tib. If you've got a younger patient that you have got that range of motion and you do want to look at doing some correction, then the medium density device would be better. It's got a 4mm medial heel Skive built into it, so we always used to think that you could only have that on a casted device, but as I say, this has already been incorporated. And also, quite importantly, it's got a lowered arch profile. So if you think back to one of the original slides at the beginning of this presentation, when I talked about that medial bulging that you get where you've got hardly any arch profile at all on the patient's foot, this accommodates that quite well. So you don't get those problems with patients coming back saying, well, I'm not sure if it's working, it feels like I've got a lump pushing up underneath my foot, because all of that has been taken away. It's got an intrinsic medial forefoot rear foot post already, but there are also additional posts that you can add to it if you really want to add and put some more correction on. So all the things we talked about earlier in the slide where we look to recognise these patients, they've taken all this into account with this device. So basically all the correction is underneath this part of the heel, and they've really maximised what you can do with that area. This bit here, as I said, has been completely removed, so from there onwards you've pretty much got a flat device which you could add bits to or you could build up, but you're not starting with the problem of having the arch either pushing the foot the wrong way or becoming uncomfortable or hard. Now this slide is just really a few thoughts, and I don't have the answers to them. As I say, they are just thoughts. For those of you that want to think further about it, or maybe critique some of the ideas or some of the research regarding a medially deviated axis. First of all, it's a biplanar axis, so we're talking about it in two planes. And if you think about the subtalar joint, it's a triplanar joint, so it moves in all three planes, so it's not taking in the whole picture. The other thing it doesn't consider is what about the soft tissue in the other joints? And that ties in quite nicely with a paper by Nestor in 2007, who said some of the smaller joints are often ignored in favour of larger ones. Well, the subtalar joint is always the one we end up talking about probably most. It's one of the is the largest joint in the foot. It's the one that we always think about controlling too much pronation or too much supination. So it almost seems as if we've talked about this medially deviated subtalar joint axis, whereas in actual fact some of the smaller joints in the foot, some of the other ligaments and muscles could well be playing a role in where that axis lies. So you could argue that should it be called a subtalar joint axis or should it be called a foot axis? And from that you could say, have we oversimplified, or has the whole theory been oversimplified? And maybe it is. But I think drawing it all together, regardless of thinking too deeply, the facts are there is a natural axis which does exist within the foot. Your prescription could be affected depending on its location, and the axis of the location could potentially make some patients more prone to certain injuries. So, as I say, sometimes I think it's very easy to look too much at the research and too much at what other people's findings are, but if we take a step back, these are the facts, and these are the things I think we need to consider when we're seeing our patients. So just a final note, whether you like physics or not, knowing the axis position allows you to work out the cause of your patient's problem in a much more structural manner. So if you know the position of the axis, it allows you to determine prevailing internal and external forces and stresses within the structural components of the foot and lower limb, although that is dependent again on in your anatomy. And from that you can come up with appropriate treatments which will be then better prescribed. So whether you go for foot orthoses, whether you go for casted, whether an off-the-shelf will suffice, stretching, strengthening, strapping, bracing, and all the other things you might do, you can be a lot more specific about what you're trying to address. It then allows you to reduce the load on the injured structured component of the foot or lower extremity. It optimises gait function and potentially prevent future pathologies from occurring again.